Thank you very much, Shreen. Our last talk for this part of the morning is going to be given by Rebecca Wong, who's a radiation oncologist at UHN. Rebecca's going to talk to us about imaging, and then we'll have time for a break and questions for all of us.
Thank you, Sylvia. Good morning, everyone. I'm here partly because of my role in the peptide radionuclide therapy trial. I'm the PI for the Ontario study, and therefore had the opportunity to join the clinical team looking after neuroendocrine patients. I also want to mention that, to clarify that I'm not a diagnostic radiologist. I'm a therapeutic radiation oncologist, and therefore I'm going to be talking to you from the perspective of using imaging to make diagnosis and influence treatment decisions. What I would like to talk about is, over the next 20 minutes, is the goals of imaging, and the key imaging tools that we perhaps have some discussions as to when to use them and how to use them, specifically CT, MRI, and nuclear medicine imaging. And finally, a few words on factors influencing the choice between them. You've heard a lot about the very different types of neuroendocrine tumors. They arise from different places and have different pattern of metastatic disease. And as a result, we will use different tools to characterize the local extent of disease, and when they metastasize, the distribution of disease and how this will guide therapy. So the key question throughout all of this is, how would the imaging tool influence our decision making? And that influence which ones we choose and how frequently we do them. For tumors that we're thinking about localized treatments, specifically the primary tumor, or in situations where the metastatic disease lends itself to local therapies such as surgery and radiotherapy, clarification of the extent of disease using detailed anatomical imaging is really helpful. In other situations, the distribution of disease is more important, and the pace of change is more important, and the local appearance and how far they extended locally is not as useful. Determining the extent of the disease, we think about local extent, the regional disease, especially in terms of local regional lymph node involvement. And we wanted to guide therapy. We want to use it to prognosticate and to problem solve. I just want to highlight that sometimes we use multiple imaging tools to problem solve and for any one situation. Computerized tomography, that's the workhorse of any oncological staging, and that's true for neuroendocrine tumor as well. It uses X-rays, and there's a detection panel at the other end directly opposing, and it spins around. You're all familiar with that. And using computer algorithms is able to reconstruct images representing an anatomy underlying the surface. We use additional contrast to help delineate and see things better. And specifically, we use oral contrast to fill different parts of the bowel, and the timing of it differs depending on which part of the bowel we want to see in detail. And we also use intravenous contrast. And again, the timing is important, and the pattern of enhancement at different phases tells us different things about the tumor. In this example, you can see that in the liver, the image on the left shows a dark spot, and on the right, it similarly shows a couple of dark spots. But the different degree of dark spots, and as we scroll through the different image sets, tell us more and characterize what the tumor is. On the left, it's really dark, the edge is really clear, and it's consistent with fluid within this very well-defined lesion, and it's a simple cyst, and there's nothing to worry about. On the image on the right, underneath the arrow, much smaller, is a little hazy, the edge is fuzzy, and that is more characteristics of a metastatic lesion. Magnetic resonance gives us a lot more diagnostic information, and it relies on a strong magnet that polarizes the cells, and when the sequence is completed, the energy that is put into the cells then result in emission of energy, and is picked up by the detector at the end of the image. And that is used to reconstruct the images similar to CT, but with providing more detail and characterization. There are many different sequences that are used, T1 and T2 being the most common one that are used, and there's some that are more investigational. Here we also use intravenous contrast, and gadolinium is the most common one. It doesn't cross-react in terms of sensitivity, so patients who react to CT contrast can usually safely have gadolinium contrast. The other contrast that occasionally is used is Primavist. It specifically goes to the hepatocytes, so it provides more ability to distinguish between tumor and normal lesions that sometimes are difficult to distinguish based on the previous scans that we talked about. Here's an image set of the same patient that I showed you earlier on. On the right, you recognize the little fuzzy lesion that I pointed out previously that's underneath the green arrow that looks more like a tumor. On the left is the MRI image that is of the same patient, and you can see clearly that the red spot under the spot under the red arrow is bright, and that represents the fluid and this cyst. And on the right, it's a tumor, and depending on whether it's an arterial phase or venous phase, the contrast washes out of the lesion and is characteristic of a lesion. So we use these type of pattern changes over time and against each other to make diagnosis and problem solve. The other thing I want to point out is that depending on where we want to look at, the window that we use determines where it's going to see it clearly, and other areas becomes fuzzy. In certain anatomy where the adjacent tissues are difficult to distinguish between normal and soft tissue, MRI is particularly useful. Here is an example of a patient that has something going on in the spine. The structure that is quite right at the back is the spine, and the little darker spot in the middle is the spinal canal with the spinal cord going through it. You might be able to see a little fuzziness in the spinal canal. But if you scan towards the left, which is the MRI, you can see a lot of white tissue inside the spinal canal. And in this patient, there's tumor growing within the spinal canal, pressing on the spinal cord, which delineates the area of tumor versus the spinal cord really clearly, and allows us to plan surgery, radiotherapy, etc. And this type of distinguishing features similarly apply to other areas of the body, determining whether a pancreas lesion is resectable, a liver lesion is suitable for local therapy versus others. That is really important, and MRI is very useful. The other feature I want to point out in the scan is if you look at the MR image on the left, everything else around it is kind of fuzzy because we want to look at the spinal cord really clearly, and the images is focused around there. So it's very and with each area that we want to see, there's a sequence and there's a different image area that we image, so that an MRI of the whole body doesn't really exist in the sense that you have to image each area sequentially, whereas CT, you can see everything more comprehensively. And that's also the reason why a lot of times CT are used to monitor changes after therapy, and MRI being reserved for more detailed assessments. Beyond anatomical imaging, looking at the size, the shape of these abnormalities, the nuclear medicine imaging is particularly important for neuroendocrine tumors. It utilizes the molecular characteristics of the tumor cells and versus normal cells, and allow us to target special markers on the surface and light them up for us to see on an image. And you've heard already, and you know in neuroendocrine tumors, there's an overexpression of somatostatin receptors, especially on well-differentiated tumors. And we exploit that for both diagnostic and therapeutic purposes. Basically, there's this target we want to see, and we attach, using a ligand to attach a radioisotope, something that will light up on an X-ray, to the substance that would find itself and identify the cellular markers. And when the tumors have overexpression of these, a lot of these radioisotopes will then tag along to the cancer cells and not so much in the normal cells and allow it to light up on an image. And that's basically what radiopharmaceutical and radiotherapeutics relies on. Somatostatin receptor images only came into the picture for clinical care back in the 1990s. And in 1992, Scan came into clinical practice and widely used and continue to be used to this day. The radioisotope that's being relied on emits gamma radiation. Gamma radiation can be detected using a gamma camera, and it looks like the picture up here, and many of you have seen this. When the gamma activity is emitted, it goes in one direction and is picked up by the gamma camera. And by using that, we can reconstruct an image similar to what we use to reconstruct CTs and MRI to show us where the tumor is distributed. Here's an image. The one on the left is a CT scan going through the lumbar spine, and the spine looks pretty normal. However, because scans can find the cellular tumor markers, it will attract the radioisotope that we inject into the patient. And on the scan on the right, you can see the darker spots, which is where the radioisotope is concentrated, represent the presence of tumor. In this patient, you can see that there is abnormality in the lumbar spine and in other parts of the clavicle and sternum higher up as well. The same principle is being used to monitor patients after lutetium therapy, for example. After we inject the lutetium, because lutetium emits both beta as well as gamma, we can image the patient after the treatment and see whether the disease is changing over time without resorting to additional images. The same principle can also be used to quantify the amount of activity taken up by normal tissues and use that to adjust the dose that is being delivered for therapeutic purposes in lutetium therapy. In this example, what we try to do is we put region of interest on the kidneys and the spine and be able to plot these curves, and the area under the curve demonstrate the amount of radioactivity that is picked up by the kidney, and in what we would call personalized dosimetry to adjust the radioactivity dose that is injected in subsequent cycles, which is actively being used in trials across Canada. The other tool that we use then is PET scans, Positron Emission Tomography. It uses a different isotope. This one emits a positron, typically the one that you are excited about is a Gallium-68 that is coming into our practice more in a routine basis now. The radioisotope that is being used emits a positron. When the positron hits material, it emits two opposite direction photons, and that is picked up by the PET scan and use that to reconstruct images. It's particularly nice because it goes in opposite directions. It provides much better spatial resolution. And as a result, using a PET scan, the spatial resolution of an abnormality is by millimeters, whereas with an scan, the ones we talked about earlier, the spatial resolution is closer to about a centimeter. So it gives much clearer images and allow much better pickup of tumors and exactly where they are. Here's a picture of the gallium scan. On the right is an arterial scan showing there's something going on in the spine. And you can superimpose that onto a CT scan to provide more details. But on the scan on the left is a PET scan, which shows much clearer definition of the area of abnormality. Here's a much more dramatic example, the same patient on an arterial scan versus a PET scan. Here we can see the distribution of disease much more clearly. And if knowing exactly where it's distributed is important, the gallium scan is a much more useful tool for that purpose. I'll jump through these slides. Diagnostic property of a scan and when to use them relies on a number of metrics that physicians use to quantify when we should use them and not. There are terms like sensitivity, specificity, accuracy, positive predictive value, negative predictive value, receiver operating characteristics. I'll come back to some of this in the next couple of slides. And all of these metrics can change depending on who you're doing the scan on. If you do it in the room full of the general population, these properties will be different compared with a room of patients who have this disease versus a room of people who have already have some of these scans or blood tests that narrow them down and make them more at high risk of having abnormalities and doing scans in that population. So understanding the context in which it is used is really important. In addition, these metrics also change depending on whether you're talking about the sensitivity and specificity of the lesion, of the primary lesion versus the metastatic lesion. That also changes. Ultimately, it's how likely we're going to change the treatment decision that is an important metric. And increasingly, that metric is being quantified as well in papers that guide physicians as to the best use of these tools. It's just a pictorial demonstration as to how we think about balancing harm versus benefit. Here I'm trying to represent the red, which are patients who have cancer and the test is positive. And on the right bottom corner are the purple ones where it doesn't have cancer, but the test is positive. Obviously, the one on the right is much better. You're picking up the patients who have tumor, and very few of them have a false negative. The false negative of these tests, of any tests, is important because the patients are flagged as having an abnormal test, and then you do additional tests, sometimes that involve tests that have some risk to them, biopsies, et cetera, which can be, in operations, it could have serious consequences if we are doing tests that have a significant false negative rate and interpreting it out of context. The situation is even more complicated if you think about patients who don't actually have the disease, represented here in yellow and white. So the white ones do not have cancer and the test is negative, so that's good. And the yellow are the ones that has cancer, but the test is negative. The ones that are in the sort of white rectangle, if you will, are the people that are harmed by having this test. Emphasizing that the test on the left is poor and the test on the right is better. Based on these combination of characteristics, we choose the test that is most suitable for each situation. Gallium-68 dotatate scan has a very good sensitivity and specificity and accuracy profile. And that's why that is frequently advocated for the staging workup of neuroendocrine patients. The metric that I talked about in terms of impact, in many of these studies is demonstrated that about 71% of patients, the use of the gallium scan changes the treatment decision. And the change is usually by guiding surgery and by guiding the selection of patients for radionuclide therapy. Here are a few case examples to illustrate how it's being used. This is a 55-year-old patient who has some rectal bleeding. On examination, have a rectal lesion. And MRI shows that it's being worked up as a rectal cancer, but only on biopsy was it confirmed that it's a neuroendocrine tumor. Staging workup with CT and MR shows that it's only localized into the primary, and what should be done about it? So if it is localized, surgery is usually indicated. So would additional imaging here help to direct, confirm surgery to be the right treatment? Yes, it would. If we find evidence of metastatic disease, the surgery would probably not be conducted because the patient may be better served with systemic therapy. So as a result, gallium scan will be suggested for this patient. In this scenario, a 40-year-old patient, similarly with a rectal tumor, known to have metastatic disease, and the biopsy have shown that is a low Ki67 index of 5, and have known liver disease. The patient had been treated with long-acting somatostatin, and now we're showing that the disease is progressing. And you can see on the liver there are new lesions that are being shown, and the lung, there's some borderline abnormalities. Radionuclide therapy is the next treatment option being considered for this patient. Is it going to be helpful to do additional scans? Yes, it would, because if we know that this patient have an overexpression of somatostatin receptors, lutetium therapy could be effective in slowing the pace of this disease and potentially prolong disease survival and overall survival. So that will be a useful tool to test to do. In this situation, the patient, a different patient, have started off long-acting somatostatin and is doing well. Would it be useful to repeat the gallium scan? Probably won't be, because if the patient is doing well on the long-acting octreotide, doing another scan to show the distribution of diseases is going to be helpful. This is a different patient that has had radionuclide therapy about 2 years ago and is feeling well, and similarly the lesions are responding, but the bone scan looks more prominent. Would doing additional scans help? Here we interpreted that the increased prominence in the bony lesions to be consistent with healing. That sometimes do happen, especially in the bone. And since the patient is feeling well, the liver lesions are shrinking, it's all consistent with response. So additional imaging isn't going to be indicated. And he can go off to his holidays and not to hang around the hospital to get additional imaging. This is a situation where the patient have a borderline Ki67 index on a higher range, and there's gradual progression of disease. When we did the gallium scan to work the patient up for radionuclide therapy, the report comes back to show a clinic score of mixture of 2 to 4. 4 is definitely a high expression, and 2 to 3 is not so much. And that's the image on the left. You can see the 2 bright spots in the pancreas, and you can see similar features elsewhere. Here we can use FDG scan to help us distinguish whether these the borderline lesions are going to be a problem for us in using radionuclide therapy. FDG lights up areas where the cells is very active and therefore represent poorly differentiated lesions. And those are the cells that is not going to respond to radionuclide therapy and cause treatment failure. The FDG scan on the right side showed that the bright spot on the left didn't light up. So it indicates that these borderline lesions are not poorly differentiated, and therefore the patient potentially can benefit from radionuclide therapy and move on to the treatment phase. This is a similar scenario. The patient have a mixed response on the gallium scan, and the top one is the image that you could see showing the lighting up of the tumor. Similarly, we did a FDG scan, which is the one shown on the bottom, which now shows a significant uptake in some of these areas, which suggests there is a high distribution of poorly differentiated lesions, and therefore this patient is unlikely to benefit from radionuclide therapy and should move on to the systemic therapy. So using a combination of these images allow us to problem solve and predict what we should be doing with the patient. There's lots of information out there, and physicians find it hard to keep up. And to guide how we should set up policies as to which tests to use, guide ourselves, and move with the times, systematic reviews are frequently used to collate the literature. And this is just a very comprehensive look with specific guidelines as to finding all the appropriate papers that is relevant to the question that we're interested in. And we did that for gallium scans. We looked for all the trials that addresses this area and found the papers that are relevant to answer the question as to whether we should be using it. And what we found is that 45% overall in the literature, when we did this about a year ago, 45% of patients, the change of management was found. And these changes were predominantly in planning surgery, just like I showed you with the rectal cancer patient, and for patient selection for radionuclide therapy. The important negatives are also highlighted. There's no advantage over CT in assessing response, and there's no data to show that it is useful in surveillance. So I'll jump through these slides, but go to here. So that's formed the basis on the Ontario PET Gallium-68 access. I think something that you've all been waiting for. Because Gallium-68 is not Health Canada approved, and why it's not, there's a lot of political and financial reasons. Hopefully one day it will. The mechanism to be able to get access is through oversight of a clinical trial. So this is a strategy that is undertaken. We designed a trial that allows Gallium-68 PET scan to be used under specific circumstances, aligning to what the state of the art of the knowledge shows us. So for patients who we find that we needed to diagnose the lesion, the patients where we can't find where the primary is, where we want to distinguish whether the patient wants to go for surgery versus radionuclide therapy. Those are situations where the inclusion criteria are specified for this trial. This trial is now active, and physicians can now refer patients for this. Imaging is also very useful in actually directing therapy and incorporated into administration of therapy. You'll be hearing more about use of TACE, embolization, radiofrequency ablation, and radiotherapy uses it routinely, and it's a critical part of identifying the area and planning the treatment. So in summary, imaging is worth doing when it's going to change decision-making, be it staging, guiding treatment decision, prognosticating, and problem solving. I've given you details of when we'll use MRI and functional imaging. Accessibility in improving with the evidence is moving and changing with the times, and certainly your advocacy to make it available, make it happen much more expeditiously working with the community. Thank you.
Thank you, Rebecca. So with that introduction on the information about NETs, I'd like to close this session, invite everyone to go for a break. We will start again in about 10 minutes. We're a little bit behind schedule, but we will start at 10:20. I have 10:10 now, so 10:20 for the next session. Facilities are all outside. We'll have questions afterwards, yes.